Dirk, if you see a patient either with very local regionally advanced or metastatic disease, how do you stratify the patients in your mind, and how do you explain this to the patient? That is, what biomarkers or what criteria do you use to classify the patients in your own mind into risk groups?
So with localized disease you're talking about?
Well, no, either advanced localized disease, as Caroline is discussing, or, and you know, her opinion is these are patients who are metastatic, and I think we all agree. So it's a metastatic patient. How do you classify them in your mind? What biomarkers, what criteria do you use?
So I mean, usually these patients which have some limited tumor growth or tumor load, they would be normal LDH. Usually they would be in good performance status. And so I think these are those patients, whatever you give, targeted therapy, immunotherapy, have the best chance to get a complete response. And also we have obviously in these cases also surgery and radiation therapy, which is helping us possibly to achieve a complete response. And I think the treatment goal nowadays would be to convert this patient into a complete responder by systemic treatment, possibly in combination with surgery and radiation therapy.
So interestingly, you're all European dermato-oncologists. Many of you have surgical training. Do you think there will actually be more of a place for surgeons or less of a place for surgeons in the future?
I think not at the very beginning. I think surgery might be the option, but I mean, if you are able to shrink the tumors significantly, there may be remaining nodules or not responding nodules. You could either follow up with radiation or with surgery.
Yeah,
Okay,
I think we will use more, but not in the aim of acting alone and getting rid of the tumor, but more helping other treatment like surgery, radiotherapy, electrochemotherapy, cryotherapy. All these things, they are more used because we have effective treatments. So the colleagues who are doing, for example, radiotherapy, now they accept to do more for us because they know that we have hope.
So now actually we'll give more work to the surgeons and the radiotherapists.
I think
well, that's
so.
probably a good thing for them. But tell me, when you see the patients with metastatic disease, what tests will you do? That is, what biomarkers are you going to assess on the tumor, in the blood, whatever, when you see them up front to help you stratify for risk and to choose a treatment?
So I think the first thing what you need to do is test BRAF mutation. I think that's the first thing which is helping you to decide whether the patient would also be eligible for a BRAF targeting therapy, BRAF-MEK, as a new standard for this.
And will you PD-L1 test them routinely, Axel?
I think it's not a routine test in Germany simply because the PD-L1 negative patients are doing quite well. Maybe not as good as the PD-L1 expressing patients or high expressors, but therefore it's not belonging to the routine. But you know, this might change over time, but it's not a selection criterion right now for yes or no for PD-1 antibodies.
But Reinhard, you've done some work in this field. Do you think PD-L1 testing is simply a surrogate for a, quote, hot tumor with a T-cell inflamed environment?
Well, we, as an academic center, I think we have to get forward and get new informations, and therefore we do much more than just BRAF testing. So we have a gene panel that is applied to every patient, and we are doing immunohistochemistry on all tumors that are resected, including PD-Ligand-1 staining and CD8 counts. And with this, we hope we can develop criteria that help us to assign patients to certain therapies. But this is an academic setting, and I still think that melanoma is a disease that should be treated in an academic setting, because we can expect so much progress if we collect the patients and follow them carefully and do, in addition, a high-profile workup. Therefore, we do it, the utility, and it's also written in the ESMO guidelines. We think that PD-Ligand-1 might be the first marker used for treatment decisions, not alone, so certainly maybe in the context of other markers. And the decision is only anti-PD-1 monotherapy versus combination therapy, anti-CTLA-4.
I completely disagree.
How so?
No, I think PD-1 ligand marker expression is absolutely not ready for prime time. I mean, there are so many differences in the different test systems we have. We have no alignment of the tests. We have tests which produce 80% of tumors which are positive, and other tests from other companies are having only a 20% positivity rate. We have so many artifacts introduced in the testing by handling the tissue, not only the antibodies we are using. I think we have to come to other methods measuring these markers, whether this is nanostring or whatever, we have to find out. I completely agree this is a hot topic of research. I completely agree that testing already now ligand expression, PD-1 ligand expression, has prognostic value for the patient. But I think if you look, for example, also on the response rates with a combination of Nivo and Ipi, it's much higher than monotherapy, also in PD-1 ligand positive patients. So I think that's absolutely not ready for prime.
Dirk, I have to tell you, I just had a patient 2 weeks ago, an elderly patient who progressed after targeted therapy, and then I had his metastasis, and and it was clear that he will switch to immunotherapy, and together with the pathologist, we saw the histology of his tumor, and it was absolutely negative for PD-Ligand-1. Actually, I would have loved to put this patient on anti-PD-1 monotherapy because he has a number of comorbidities where I think he might suffer a lot if he has the combination. But with this histology in front of me, I could only say, if we switch to immunotherapy, we have to use the combination.
So what was the final decision? What did you decide to do?
He went on an ipilimumab and nivolumab combination therapy, and actually he had a very deep complete response. And the other thing I tell you, we also had the tumor load of this patient and the mutational load of this patient.
What is a very deep complete response?
A very deep complete response.
Well, 80% by 12 weeks, I guess, was the original criteria in the Walchuk paper. This is arbitrary, of course.
Even in the bones.
It's deep
Even
complete
in the bones.
response.
Yes,
This
we
is
have
complete
also a
response.
number of patients who responded in the bone.
I think we all agree that this test might be interesting in the future when it's optimized. Right now, it is not. We cannot use it routinely.
I know, it sounds like we all agree it was a great concept, but it's not quite ready for prime time.
Optimized and used with other marker, probably.
But in risk stratifying your patients, how often do you use the criterion just of clinical pace of disease? I mean, Reinhard, do you look at it that way?
No. Yeah, well, we look at this and we monitor this and we try to find out the consistency over time. So if we have multiple metastases from one patient, we are working on this. We are doing the correlations with other markers like IDO expression, like CD8 counts. But I think it's too early to draw clinical conclusions out of these data.